So in this revision session, we will be doing a lot of images for you, and this is a very important thing that you are seeing in front of you. So kindly comment on the procedure. We'll be discussing a lot of images in this. So okay, so comment on the procedure. Where is it indicated? This is actually a bowel lengthening procedure, a bowel lengthening surgery. And what is this bowel lengthening surgery better known as, students? Yeah, this is a longitudinal, longitudinal, or this is a, so this is known as lilt, this is known as lilt, and this is indicated for short bowel syndrome. If you want to see this short bowel syndrome in detail, I have already uploaded a video on short bowel syndrome. I've already uploaded it on this on my YouTube channel, so you can go through that. But yes, I will have a brief discussion on this. Yeah, okay. So let us try to understand this concept of short bowel syndrome and what is it needed, why is it needed for. So 5 important questions related with short bowel syndrome for your exam. So short bowel syndrome. So when we talk about short bowel syndrome, as the name says, that the length of the bowel is decreased. So you can say that what is the criteria. There are a lot of people who teach a lot of things. One very simple thing is length less than 200 centimeters, point number 1, or any length of intestine associated with process of malabsorption. So any intestine associated with malabsorption. So this is what is very important. So length less than 200 centimeter or any length. So this can be associated with diseased bowel, diseased bowel. So if there is, suppose, the tuberculosis, again that will result in very same thing. Suppose if this is a case of Crohn's, if this is a case of radiation enteritis, again the same thing will happen. So what we are planning to do in this surgery, this is what is very important. So I'm not going to detail. So what is the classical management of short bowel syndrome? This is what I will discuss with you. The first line, and this is also the treatment of choice, this is the conservative management. Now when we talk about conservative management, what is conservative management? Students, the bowel length is less. So if the bowel length is less, how can we compensate? Do you know all the intestine shows a property of adaptive compensation? So what is that? Adaptive compensation. So if we decrease the transit speed, so we need to decrease the transit speed, point number 1. We need to increase the efficacy of intestinal juice. So this is what we actually concentrate on. So how can we increase the efficacy of intestinal juice? Answer is by reducing the acid level. So therefore PPIs. Now this bowel will adapt, but meanwhile you need to source something for this immediate time, because bowel is not absorbing. When your body is not having any nutrition, then how will you survive? So we will have parenteral nutrition. So we will go for home TPN, and along with that you will start strengthening your bowel. How can you decrease the speed? Yes, you have a lot of agents, na? You know, loperamide. So we have loperamide, which actually decreases the speed. What else? Do you know there are some molecules like GLP-2 analogs, na? GLP-2 analogs, we have bombesin, we have incretins. So we use these GLP-2 analogs. Now when we talk about GLP-2 analog, the one very important is teduglutide. So teduglutide is a natural neuroendocrinal brakes which will reduce this. So this is how we basically concentrate on. So anything which can reduce the bowel speed or motility is very important. Again, the intestine has bile, and bile has a cathartic effect. So along with that, you also need to put bile acid sequestering agent. So cholestyramine, this is again very important. So bile acid sequestering agents. So this is how we manage it conservatively. Students, I hope that's clear to everyone. Now when we talk about surgical intervention, now this is what is very important. So if the medical management fails, then we go for surgery. And when we talk about surgery, there are 2 important things that we need to understand in this. One is the intestinal transplant surgery. So we have intestinal transplant. This is what is very important. and the another one is the bowel lengthening. So non-transplant surgeries, it comes under the concept of non-transplant. When we talk about transplant, that's okay. Non-transplant, we have electrical pacing, so you can electrically pace the gut, so that is okay. That is a bit more of theoretical we do, but we not, that's not very prominent. Then the second is reverse bowel you can say reverse bowel interposition. What is that reverse bowel interposition? So a segment of bowel, suppose this is the bowel, suppose this is the bowel, and this is how the things are. So what I shall do here, I shall reverse this segment, I shall reverse this segment. Now when you reverse this segment, so I will change the orientation of this segment. Just see, I have just reversed this segment and I put it. So when you actually reverse the segment, the flow will drastically be countered here, because this is having a what, reverse flow, and that is how you are going to increase. So they are going to act like your what, natural speed breakers. So this is what is again very important. And third is the lengthening surgeries. So when you talk about lengthening surgeries, what are the two classical lengthening surgeries we have? We have two surgeries. The first is Lilt. Lilt is also known as Bianchi's procedure. Lilt is also known as Bianchi's procedure, and the another one is known as step. Another one is known as step. So we have Lilt and we have Bianchi. So they are very important. So when we talk about Lilt, that is known as longitudinal incision lengthening plus tailoring. So lengthening plus tailoring. It's a very simple kind of surgery that you actually see. So if this is the bowel, let us take this as the bowel, and this is the mesentery of the bowel. So we are going to split this along this. So we are going to divide it in between the mesentery. We are making a split and we are going to divide. So this is one segment of the bowel, and this is one more segment of the bowel that has been generated. And then we are going to do an end-to-end what? End-to-end anastomosis. So this is how we anastomose it. And can you see, now you have increased the length. One student will say, sir, okay, the length has been increased. Can you see here? The length has been increased, but the point is that the lumen has been reduced. So nothing, don't worry about that lumen part. Lumen will gradually increase. Students, if you get a very good question, you can get a question that what is the minimum diameter of bowel required? At least the segment which is chosen for Lilt should be more than 4 centimeter in diameter, because if it is less than that, it will be too less. So there is a risk of what, post operative stenosis along that. So, and lot of things can happen. The another one is step. So what is the concept of step? The step is I hope everyone is getting these concepts. So serial transverse enteroplasty procedure. Now what is this concept of step? Now this is again very important. Try to understand step. So if this is the bowel, if this is the bowel, if I have to travel inside this bowel, I will travel like this. So this is actually the conceptual length of the bowel. So what I will take GI staplers. I hope you must have seen GI staplers. If not seen, you can see my videos on stapler. I've shown a lot of, you can say, staplers. You can go to my YouTube channel and see there. So what you will do, you will fire the staplers, and when you fire the stapler, you will fire them like this. So this much part of the bowel you will remove. So when you remove this much part of the bowel, so the actual bowel that you get to see, so this is the bowel, here you have removed it. Okay, so this is the place. So again here you have, okay, so this is the place again. Now this is, you have removed it here. Again you have removed it here. So can you see, you have removed it here. So this way you have created a lot of gaps. So this is like step. If you see the literature, this is one step. But now if you have to travel, the food will have to meander its course like this. So that is why this is how you increase the absorption surface, by making the wedge-like enterotomies. So this is what is very important. So one is step, one is this. I hope that's clear, students. These questions are very important. So comment on the flap repair shown in this diagram. What kind of flap repair? Again, this is a very important question for your exams. So try to answer me what kind of flap repair is this. I want two answers. What is the broad category, and then what is the subcategory, and what is an indication. Recently, I have uploaded a video also on this. I'll give you a hint. This is used in case of piloneedle sinus. So I have uploaded one video of a rare piloneedle sinus. You can go through that. Even though I have not done this flap reconstruction, this is classically used there. So can you tell me what flap is this? This is a category. The broad category of this flap is it's a transposition flap. So it's a transposition flap. This is what is very important. Very important. It's a transposition flap. Excellent. What kind of transposition flap? It's a rhomboid flap. Very good, Ankit. Very good, very good. I hope students are enjoying. So rhomboid flap. And what is the name of this flap? This is a Limburg flap. This is also known as a Limburg flap. So let us try to understand what is the concept of this transposition flap. You are doing nothing but you are transposing the flap. You are stretching the flap and bringing it down. So that is what is the category. That is what is the broad category. And Limburg flap or rhomboid flap, this is where. So if you talk about the use, this is for recreation of rhomboid defects. And where do we use this? Classically in case of piloneedle sinus. The classical example for this is a piloneedle sinus. So more on this, what are the four classical type of flaps that we have to understand? They are very important. Let me quickly revise. I shall take 5 minutes of yours and quickly revise. There are two things that you are often confused with. One is graft and one is flap. I hope you know that it's a graft is a block of tissue. It's a block of tissue for reconstruction. Basically, both of them are used for reconstruction. So block of tissue for reconstruction. And we talk about the flap. Yeah, it's a vascularized block of tissue. So if you talk about the concept of graft, it's nothing but a skin patch placed over the defect, where you leave the skin patch at the mercy of the recipient side, that okay, if the blood vessels develop, there will be vascularity. If it doesn't, then it will not. And this is a vascularized block of tissue. And this is again used for the purpose of the reconstruction. What does that mean? That flap have a better planning for survival because they carry their own blood supply. So they have a better survival rate. Quickly, let us talk about what kind of grafts do we have. So when you talk about the grafts, now this is what is very important. When we talk about the grafts, we have to understand based upon what thickness and what composition we are using them. So it could be a split thickness graft, it could be a split thickness. Since this is a quick rapid fire revision, I will not go for a lot of depth. So ST-SG is what we call, they are most commonly used graft. And actually split the thickness. So split thickness skin graft have three categorization. Now this is what is very important. So they are thin, they are intermediate, and they are thick. So last year we got two questions. One was on the contraction, which I am going to tell you very soon, and one was what is the name of intermediate. So thin variety is actually the most popular. Why, students? Because this is having the maximum chances of survival. Are you getting this point? Thin variety. So when we talk about thin, what is it also known as? This is known as Thiersch-Ollier graft. This is known as Thiersch-Ollier's graft. Are you getting this? What is the thickness? What is the thickness that we actually look forward? This is less than 0.006 inches. Are you getting 0.006 inches, or you can say 0.006 inches to 0.12 inches. No need to remember the figure. Then when we talk about the intermediate, what type of graft it is? Tell me, intermediate graft, what it is also known as? This is also known as Blair-Brown graft. So it's known as Blair-Brown graft. Next is, what is the thickness for them? 0.012 to 0.018 inches. Not very important, but if you remember, it's good. The thick variety, this is also known as Paget's graft. So this is known as a Paget's graft, and this was the question that was asked. What's a Paget's graft? more than 0.018 up to 0.024 inches. No need to remember everything. Then we have one graft where we do meshing, because now the problem is, like if there's a defect, and you want to cover the graft over this, there could be a possibility that you don't have that extra skin, or when you take out that extra skin, there will be a big contralateral or counter defect that will be created. Sometime what we do, we make the holes in the graft. Now what is the advantage of making the holes in the graft? When you make the holes or the meshes in the graft, you actually weaken the graft, because if I make it porous, there will be weakening of the graft, yeah, and then I can stretch it. So the advantage of a mesh graft is that yes, you can stretch it. So this is what is very, very, very important. So this is what is known as a meshed graft. So meshed STSD has two advantages. The first is that it increases the graft surface area. So increase in the graft surface area, this is one very important thing. The second one very important thing that you need to understand is, since it is porous, all the hematomas, what is the most common cause of, tell me what is the most common cause of graft rejection? It is the hematoma which collects in between the recipient bed and the, you can say, the graft. So there is a place for exudation. So they have increased survival, chance. Yeah, why they have increased survival? Because all the hematoma that actually you can say exudation of hematoma is evacuated through the fenestration. So this is what is very important. The next thing is, you cannot be greedy. You cannot say I will take a small size skin and make a sari and wear beautiful, I become a mermaid. नहीं, ऐसा नहीं करना है बच्चे. There has to be a definite surface area. So what can be the maximum increase in mesh graft? Now I want to know this. Maximum increase 1.5, 1 is to 1.5 to 1.6 times. This is the maximum. इसके beyond अगर increase करता है, so what shall happen, student? If it increases beyond this, the only fate for that graft is that graft will get dehisce off. Are you getting this point or no? So these are the must know points on the graft. Flaps, yes, we have the two kinds of flap. Let us quickly discuss on that also. When we talk about the flaps, there are two kinds of flap. One is the axial pattern flap and one is the random position flap. Sir, in graft, shouldn't we account for vascularity too? Yes, students, you have to understand, that is why we take only the dermis, we need to remove everything. So there are three stages of grafting. I hope you know: imbibition, inosculation, and then third is revascularization. The first 24 to 48 hours, imbibition, where there is deposition of plasma and fibrin in between the graft and the recipient bed. The next 48 hours, the stage of inosculation, where there are small capillaries starting to form, and this is going to provide the nutrition and moisture to the dying or decaying graft. And then the stage 3 is the revascularization stage, that happens on maybe on the day 5th or day 6th, where there is well formed capillary. So if the graft has to survive, this is what is known as take of the graft. It has to be there for 6 days. If it survives beyond 6 days, it will not decay. If it has to, it will become blackened. It will blacken within 6 days. Are you getting? So the time of take of the graft is 6 days. So when we talk about the flaps, there are two kinds of flaps that we have. One is the random position flap. And then the second one is axial pattern flap. So random position flap and axial pattern flap. Yeah. So tell me, what is the difference between the random position and the axial pattern flap? Answer is Mera Baap Kaun. What is that? So do you know who my father is? We talk like, you jante ho na mera father kaun hai? So yeah. So if that father or the blood supply is a known eminent person, yes, that matters. So the blood supply, if you talk about the blood supply, is a known anatomical vessel. So we know like latissimus dorsi, thoracodorsal pedicle. We know transversus abdominis muscularis, the tram muscle is supplied by deep inferior and superior epigastric. So we know these blood vessels. Now when we talk about the skin is also supplied by some dermal nerve, dermal plexus or subdermal plexus. So do we have the name for all those millions of dermal and subdermal plexus? That is what. So known anatomical blood supply. So known anatomical blood supply, if we have, that's an axial pattern. and if we have unknown, dermal, subdermal blood vessels behind that, that is what. So unknown blood supply versus known anatomical blood supply, they are very, very, very important. So I hope you know the classical examples of TRAM is a axial pattern flap, latissimus dorsi, trapezius, all those blood vessels which we can tell of. Yeah. And then when we talk about random position flap, I have told you one is a transposition flap. So transposition flap, and this accounts for Z plasty. I hope you know the aim of Z plasty is the lengthening. So we have Z plasty, and then another one is rhomboid flap. Rhomboid flap. Then second one that we have is what, students, is a rotational flap. It's a rotational flap. The third one we have is advancement flap. What is advancement flap, students? Imagine there's a wound here, and I want to cover this. So I will advance the skin over this defect. Can you see? There's a wound here. I will advance the skin. So this is what is sliding of the skin over the wound. So based upon the shape, we can have a rectangular advancement flap. So it could be rectangular advancement flap, or it could be VY advancement flap, two types. And then fourth is interpolation flap. So when we talk about interpolation flap, or we also call, because many of the students must have studied from me, and I taught interposition or interpolation are the two and the same word for the same category. So you are using, this is a very unique form of flap, where this is a type of transposition flap for regional reconstruction. Remember, all the random position of flaps, if you talk about their capacity of reconstruction, they are used for local reconstruction. And when you talk about axial pattern flap, they are used for local, for regional, and also for remote reconstruction. So axial pattern flap, you can take the flap along with that blood vessel, you can trust, because that blood vessel can be harvested. It's a big vessel, you can take it via free or via pedicle concept. But these vessels are not, if you talk about dermal, subdermal, these vessels are not able to go, first of all, to a long distance, and their lumen is so small that they cannot be anastomored to the recipient side. So ये सिर्फ local reconstruction में use कर सकते हैं. So now we have an example of a Thenard flap. What is this Thenard flap? Let me tell you something about the Thenard flap. Suppose if there is injury to this, so let me tell you, if there is injury to this skin, injury to this fingertip. So suppose my fingertip has been injured. So what I can do, okay, yeah, this is suppose how the things are. So this is the Thenard eminence. I will fix this skin. I will fix this finger with the skin, and now after few days I will cut the skin, and the Thenard eminence will take up that skin. So this is what is very important for you to understand, that the Thenard eminence will take up, the Thenard eminence skin will be taken up by the finger. So you are using the Thenard eminence skin over this point. So this is hand and the same anatomical region. That is why the fingertip reconstruction by Thenard flap is a classical example of interpolation flap. In nutshell, one more or two more points. What is the most common cause of graft rejection? The answer is hematoma more than sepsis. So hematoma is the most common, hematoma more than sepsis. The second is most common cause of flap rejection. What is the answer, students? Vascular compromise. So vascular compromise. So arterial and venous compromise, they are the most important reason. So I hope the flap, we have quickly revised a lot of things in flap. So come on, quickly answer this question. What is the name of this classification? I will not go in further depth, because in last video I have already discussed a lot of things on this. So tell me, what about these zones? So these are the zones of burn. These are the zones of burn. And what is the classical name for these zones? Answer is, we call them by the name of Jackson's. So these are the Jackson's zone of burn. Jackson's zones of burn. They are very, very, very important. So zone 1 is the zone of coagulation. Zone 2 is the zone of stasis. And zone 3 is the zone of hyperemia. This is the farthest zone. Why it is known as zone of hyperemia, students? Because this is a zone where you have vasodilatation. Are you getting this? Vasodilatation. What is the zone of coagulation? This is a completely destroyed zone. So completely destroyed zone, they are very, very, very important. So completely destroyed zone. And when you talk about zone of stasis, this is the most vulnerable zone. Why it is most vulnerable? Because it is next to zone 1, and zone 1 has been completely destroyed. If you don't stop the process of burn, the burn will no time damage this also with coagulative necrosis. So it is zone of stasis. Why? Because of vasoconstriction. So there are a lot of questions related to this. One more is, which zone do you see in increase in thromboxane A2? So increase in thromboxane A2, thromboxane A2 is only increase when you have endothelial injury, and it's the zone 2. So zone 2 is the zone where you get to see increase in thromboxane A2. More of the burn in a different video. Since this is a rapid fire, we need to discuss a lot of other things also. Come on, comment on the surgery being performed here. So you can see some rocket, and this is probably an anal canal. This is a bread and butter for us. So I routinely do this surgery, and I think I do it more than averages, more than 20 surgeries a month, at least 20 to 25 of hemorrhoid surgeries I do in a month. So what is this surgery known as? Come on everyone. Yeah, I would like you to answer in the comment section below. This is PPH. What is PPH? Postpartum hemorrhage? No, procedure for prolapse and hemorrhoid. So procedure for prolapse and hemorrhoids. This is one. Or this is also known as, or what is another name for this? The another name for this is, or it can be called as a stapler hemorrhoidopexy. Stapler hemorrhoidopexy. Are you getting this? What is the advantage? The you can say post surgery recovery rate is very high in comparison to the open version, that is Milligan, Morgan, and the closed version Park and Ferguson. This is one of the best. So let us have a quick recap of some important things related to hemorrhoids. I hope you all know about hemorrhoids, and when we talk about hemorrhoids, you get 2-3 questions, that what kind of hemorrhoids bleed and what kind of hemorrhoids plain. So answer is, the external hemorrhoids, they are painful. The internal hemorrhoids, they are the anal cushions engorged with blood, so they bleed. So when you talk about the classification of internal hemorrhoids, what are the hemorrhoids? I hope everyone know, they are the prolapsed anal cushions. So internal hemorrhoids, they have 4 grading. What is grade 1? The grade 1 is a grade where this is the anal verge. Are you getting this? This is the anal verge, this is the dentate line. The hemorrhoidal cushion, they descend down, but they don't prop out of the anal verge. They are bleeding, that is okay, but they don't come out of the anal verge. What is the grade 2? What is the grade 2? Grade 2 of them, it is like, this is the dentate line, the anal cushions, they come out, they often come out. You know, there are 3 anal cushions, 2 on the right, 1 on the left lateral, right posterolateral, right anterolateral. So try to understand, they come down during defecation, so descend during defecation. This is what is very, very, very important. But they have a tendency of spontaneous regression. Are you getting this point? Spontaneous regression. So patient often in a grade 2 presents to you with, sir, the hemorrhoidal cushion come down, but they regress back. They regress back spontaneously. So during defecation, something protrudes out, but it goes back. So this is what is grade 2. Next is, what is grade 3? When we talk about grade 3, the same patient comes to you and says, sir, there is a mass protruding out, and when I talk about how does it go back, he says that the spontaneous regression that we used to see, the spontaneous regression is not possible here, and I need to manually actually reduce. So regression happens, but manual regression happens. Are you getting this point? So this is a grade 3. And what is grade 4, students? That is known as proxidentia. So when we talk about proxidentia, what is very, 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 very important? Very important. There is no regression. There is no regression in this. they're completely prolapsed, be it spontaneous, be it manual, it doesn't regress. And this is what is very, very, very important. 1, 2, 3, 4, they are very important things that we need to understand. The next very important thing is what is their management. So try to understand, when we talk about hemorrhoid as a complex entity, you need to see 2, 3 things. When you talk about hemorrhoid, whether it is external or whether it is internal. Now this is what is very, very, very important, whether it is external or whether it is internal. Now what difference does it make versus external and internal? The external hemorrhoids, they tend to get strangulated. So in this case you need to ask yourself, if there is pain, the answer could be no. So if it is no, then observation, there is no need for removing them. If it is yes, they are painful, then plan, then the duration is very, very, very important. If it is less than 48 hours, always go for surgical excision. So what is the surgery? Excision. Now if it is painful for more than 48 hours, try to understand, these hemorrhoids will always go an auto shrinkage, because this is more time required than to this is the time more than sufficient for the tissue to shrink off. So if 48 hours have already passed and it is painful, then there will be auto shrinking. So there will be auto shrinkage. So in this case you will observe the patient. Observation. Now this is what is very, 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 very important. If there is no relief, then plan a surgery. If there is no relief, then there is always a principle of going for surgery, because majority of the time it has been seen beyond 48 hours the pain doesn't, it starts to go down drastically. So when we talk about the internal hemorrhoids, now what is the plan? So for internal hemorrhoids, the next question is, what grade do they belong to? The answer could be, sir, it is grade 1. So if it is grade 1, then you have to go for LSM. What is LSM? Lifestyle modification. So increase in water, increase in fiber, and along with that decrease the tendency of constipation. So you are going to advise laxatives to the patient. The second, if it is grade 2, you have to go for lifestyle modification. If it fails, then you go for intervention. Now when you talk about intervention, there are 2 things you can go for. There is something which is known as injection sclerotherapy. So there is injection sclerotherapy, point number 1. Are you getting these 2 things? Or you can also go for rubber band ligation. So you can go for injection sclerotherapy or rubber band ligation. They are very important things. If they fail, yeah, you can go for surgical excision also. So this is what is very, very, very important. Now there are 2 questions related to injection sclerotherapy also. What is the sclerosant that we use? So tetradecyl sodium, this is one. Or you can say sodium morhuate. So this is what is very, 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 very important, sodium morhuate. Then if it is grade 3 and grade 4, then you have to go for surgical excision. Now when we talk about surgical excision, students, there are 3 things to be understood. Actually there are 4 surgeries, but the 4th one we are not doing it anymore because it has been now totally disrecommended. So in this surgery we have, the first is open hemorrhoidectomy. So a open hemorrhoidectomy, and when we talk about this is also known as Morgan-Milligan. So Morgan and Milligan surgery, this is one, Morgan and Milligan surgery. What is this? You excise the anal cushion, you can put a gauze or put an anal pack and just allow it to spontaneously get closed. The wound, the bleeding should subside. The second is, we go for closed hemorrhoidectomy. Now what is closed hemorrhoidectomy? I will write HMX. What is closed hemorrhoidectomy? So these are the anal cushions. You have excises, and when you have excised them, do suture the base so that the bleeding is avoided and reduced. Are you getting this point? And this is what is known as Park and Ferguson. So Park and Ferguson, this is what is Park and Ferguson surgery. The third that we now do is PPH. So PPH is procedure for prolapse and hemorrhoids. You want to see this, go to my YouTube channel. There are a lot of videos. I have this n number of videos. Students, the fourth is rectal advancement flap. So it is hemorrhoidectomy plus rectal advancement flap, rectal advancement flap. Now what is this? What is this? This is also known as Whitehead hemorrhoidectomy. So students, do you know that this variety is no more used? This is no more used. Now what is this rectal advancement concept? Try to understand what do they do. This is the hemorrhoidal, this is the dentate line, and suppose this is the place from where you have excised. Now this is bare area from where bleeding can happen. So what you will do, suppose this is the hemorrhoidal, above the hemorrhoid, this is suppose the rectal mucosa. So this is the rectal mucosa. What you will do, you will stretch this rectal mucosa down, bring it down, and you will just suture it over this. So this is what is known as rectal advancement. So imagine suppose this is the hemorrhoidal cushion, I have removed it, and now I will bring the rectal skin on this and cover it. Are you getting this point? Now what is the problem? The rectal skin might upfold, infold, and when the rectal skin gets fibrosed and hypertrophied, the lumen of the anal canal is drastically reduced, and this is going to lead to anal stenosis, and ectropion defect is seen. So this is associated with ectropion defect, and this ectropion defects will lead to what? Stenosis. Nowadays there is one more new, you can say, intervention which has been started, that is THAAD. What is THAAD? Transhemorrhoidal arterial devascularization. So this is a USG guided injection into the hemorrhoidal artery. So this is transhemorrhoidal arterial devascularization. So all these things keep on coming up, and they are useless, they are waste of time, because the time you will waste in them, the results that you get from them, they are not promising. So this is what is thought, in case if it is asked in exam, so my kid should be able to answer this thing. So the next question that we have, allow this video to get, yeah. So a patient presents to you with nocturnal. So I hope you are enjoying, the hemorrhoids are clear to everyone. So a patient presents to you with nocturnal regurgitation, epigastric pain. The following surgery has been done. Come on, I'll not waste a lot of time in this. I want the students to comment in the comment section below, what kind of surgery is this? So yes, this is a patient with GERD. So this is a patient with GERD, and this is a surgery which is known as fundoplication. So what is this fundoplication? Since you can see a 360 wrap, this is a 360 degree wrap. So this is what is known as Nissen's fundoplication. So the students who come for FMAS and DMAS training at my institute, so we have an association, Endo-Laparoscopic Welfare Association, where we teach students the skills of laparoscopic surgery. So you can also come and learn this surgery. This is a very common surgery which we allow the students to do in case if they are joined for a DMAS, Diploma in Minimal Access Surgery. So what is this? Plication of fundus around this. So what is the use of this, and what is this dotted instrument? This is done over a bougie. So this is done over a bougie or a boogie, or you can do it over an endoscope also. So boogie, this is generally 50 to 60 French boogie. So 60 French boogie is what we take, and this is why it is put, so that you don't tighten it excessively. Let me tell you the concept. So what is the concept of GERD and its management? The basic thing that we need to understand in GERD is that there is a reflux. So gastroesophageal reflux disorder. This is the rapid mega revision. So I will not go for actually in detail, in depth concept. I'll make a different video for GERD and its understanding, but you need to understand it. Basically, it's a reflux. So this is effortless regurgitation of gastric or biliary content or biliary fluids into esophagus. This is very, very, very simple, and this is going to lead to a lot of changes. So the first thing is, what are the factors associated with GERD? So you need to understand The first thing that you need to understand is a defective LES. So defective lower esophageal sphincter, point number one. So there is a defect in the lower esophageal sphincter. Then a defective right crus of diaphragm. So right crus of diaphragm. There are two important things. Yeah. So right crus of diaphragm, that is the corkscrew, or you can say cock pinching movement is actually not working. And then the defective angle of His, or you can say defective gastric valve or gastric flap. Now what are these three things related to? Let us try to understand. Can someone tell me what is LES? Answer is lower esophageal sphincter. So lower esophageal sphincter is not a spot. You cannot say that this point is a lower esophageal sphincter, it's a zone. Now when you talk about the zone of lower esophageal sphincter, some part of that zone, so this is how the right and the left crus are. So this is the right crus, this is the left crus, and then we have the sling fibers of the right crus coming across this. So it is the pinching action of the right crus along with its collar sling fibers. So it is going to close it. Whenever a component of reflex wants to go up, it is going to pinch and close it. The very next thing is, what is LES? So LES, some part of lower esophageal sphincter, some part of lower esophageal sphincter is there in the, you can say in the thorax, some is in the abdomen. Just a minute. Okay, so try to understand this very simple thing, that this is the total length. This is the total length. This is the total length. There are two important things. There are total length, point number one, and this length is known as the abdominal length of the esophagus. So there are two important things which maintain the tone, total length and the abdominal length. So if the total length, the minimum total length should be more than 2 centimeter. The minimum abdominal length should be more than equal to 1 centimeter, and the minimum resting pressure should be more than 6 mm Hg. If any of them is not followed, that means the abdominal length is decreased to less than 1 centimeter, total length is decreased to less than 2, there will be what? Reflux. There will be reflux, and this is what is very important thing. Are you getting this? This is very simple, very simple. Are you? So next is, what is the concept of gastric flap? Now many of you must have heard of angle of His. So if you see this, this is what is angle of His. So from outside you see this angle of His, but I see this thing as a what, student? Gastric flap. So whenever anything wants to reflux back, so if there is a reflux generated, this gastric flap comes like this and doesn't allow the reflux. So this angle of His, the acuity between the esophagus and the diaphragm and the gastric fundus, this is going to act like a what angle? The flap. So the flap will open close. So if you talk about when we talk about this angle of His, it has to be more acute. Suppose if the patient is having angle of His like this, so in this case there will be no flap effect. There will be no flap effect, and thus there will be a chaos. So we cannot change the dimension of the esophagus. We cannot change a lot of things, but one thing we can maneuver is the gastric flap. So when we talk about the fundoplication, most of you even don't know. You people mug up that there is a surgery which is known as fundoplication. You can, in my classes also have shown a lot of robotic fundoplication. I do a robotic fundoplication, very easy surgery. What is the aim of fundoplication? The aim of fundoplication is to recreate gastric flap, and this is what is very important, to recreate gastric flap. Now try to understand this thing. This is what is very important. Just see. So the first is, let me write the names. This is the Nissen's fundoplication, and when we talk about Nissen's fundoplication, this is a 360-degree fundoplication, point number one. The second is we have Dor's fundoplication, What is door fundoplication? It is 180 degree anterior fundoplication. There are a lot of Rossetti, Hell, Wilson, Will. I don't care about that because we don't do. There are a lot of teachers who 10-15 fundoplications बताते, बच्चे is useless. उनसे पूछना कभी किया है, कभी देखा है, वो कहेंगे नहीं, हमने बुक में पढ़ा है. बच्चे, that is why you don't get those useless questions. What we do, we ask. Otherwise, we don't get them in the exams. Are you getting? So next is two-pay fundoplication. There is a lot of chaos कि 180 होता है, 250, 270 होता है. बच्चे वो पढ़ाते हैं and I do that. So don't worry. 180, anywhere between 180 to 270 degree fundoplication, posterior fundoplication. This is what is known as two-pay. Are you getting this point? So what is, and the next thing that I will ask or I will tell you, what is the shape of flap which has been created. Now this is again very, very, very important. In this you have a nipple flap created. In this you have the S flap created, and here you have omega flap created. Remember, for toppers, nipple in essence, door we have S and टू पे वी हैव ओमेगा. एक बच्चा कह रहा है सर मुझे रटना नहीं. मैंने कहा रटवाना भी नहीं तुमको तो रटवाना है, तुमको समझाना है. ट्राई टू अंडरस्टैंड व्हाट इज दिस बेसिक कॉन्सेप्ट. दिस इज समथिंग लाइक दिस. सो आई विल take hold of the what? I will take hold of the fundus. So I will take hold of the fundus. Before that, what I will do, I will create a retroesophageal diaphragmatic window. So I will always create this window. Are you getting this? So this window is so behind retroesophagus, it is so casual that we can move the esophagus. And now what I will do, try to understand this. So I will take this esophagus behind. Can you see this esophagus has gone behind? This stomach, this fundus has gone behind. So we will check whether it is moving smoothly, and this is what is known as a shoe shine maneuver. And then we will actually suture it. Now we will bring and suture it. So just see how we do it. So ultimately the final image that you get, is somewhere like this. So this is the final image that you get. And can you see a nipple shape valve is recreated here. 360 degree valve is recreated. Similarly, if you do it anteriorly, so when you talk about the anterior fundoplication, you will bring this fundus and put it here. So when you put it here, you will bring some part of fundus. Can you see a staggered S created? This is an S-shaped wall. So this is what is very, very, very important. So are you getting this point? Is it hanging? The video is hanging? Or is it clear to everyone? S, omega. In some class, I will take it in detail. I have taught this topic in detail and depth. So this is my favorite topic. I love to do it. I love to teach. S shape. So similarly, if you do 180 degree or 270 degree posterior, so how it would be like? Just try to understand. If I take it posterior, so it would be like this. So this is an omega. So two-pay you get to see omega valve. S you get to see in door, and nipple you get to see in niscence. Is this clear to everyone or no? Is my audio video clear to everyone? Yeah? Is the streaming going on fine? Okay. So lot of students are enjoying the live class. So I hope you understood the concepts of GERD and its flap. So comment on the, you can say comment on the X-ray crystallography. Actually, it's looking like a very tough question, but it's a very easy question. If you know the X-ray crystallography is actually the ideal investigation to see the shape of, you can say, the stone. So what is or what are you seeing on X-ray crystallography here? Can anyone comment? Video is choppy. Yeah, I also think. Is it okay? Audio video is clear to everyone? Hi students. Yeah, there is some lag. I think there is some lag. Okay. Okay. I hope it's clear now. I hope it's there. Okay. So when we talk about comment on the type of stone on X-ray crystallography. So if you see a classical shape, is the video okay? So what are you seeing? The classical shape here is, you can see prismatic